Week 9. So last week, I know I said that career services was going to be there on Wednesday. I'm human. So they will be here this Wednesday. I promise. I already talked to everyone, all players. So this Wednesday, career services will be there. So I just wanted to kind of put that out there for everyone. The reason I said that is because both of your chapters are recorded and are up on ST310. So again, if there are any questions with that particular course, you guys let me know. Okay. One chapter was really fast, really quick. I really enjoyed recording it. But again, if you guys have any questions, concerns, here I am. But that's Wednesday. For tonight, we're finishing up chapter 18 and we are going to touch into chapter 19. We should be able to get to our Kahoot game this evening. There are only 5 questions just in case. And then we're going to wrap it all up. But before we get into everything, let's get into our quote of the week. The only way to do great work is to love what you do. And that's by Steve Jobs. Now, we as surgical techs, we are a huge part of the surgical team. I don't care what anybody tells you, we are, okay? And the work that we do is so important just to make sure that the surgeries go smoothly and patients receive the best possible care. The quote reminds me that in order to truly excel, especially in our role as surgical technologists, we have to have the passion for it. If you can't tell, I actually love being a surgical tech. It has afforded me many blessings, and I hope everyone gets to experience the joy that I have. It's a very humbling field. It's a very rewarding field. There are good days. There are days that are a little bit rough, but at the end of the day, at least for me, I've always felt humbled when, we were able to fix a patient's hip or, we get that bleeder in somebody's brain. Now, every time you scrub in, you're passing an instrument, you're helping maintain a sterile field, you are contributing to the patient's well being. If you approach each task with dedication and care, you'll find greater fulfillment in your work. When you love what you do, you'll notice that every challenge becomes a chance to learn and grow, and your efforts make a real difference in the lives of others. So, the only way to do great work is to love what you do. Now, as I mentioned, we are finishing up with chapter 18, planning a case opening and start of surgery. We just have one objective left, talking about the guidelines of preventing loss and retained items. This is big, you guys, because that legal record, that document, that medical record is a legal document. We can be subpoenaed to the judges, to the court for items left in a patient's body if our name is on that op report. This is important. Why? Because there's the risk to the patient, infection, complications. Now they may have to come back for another surgical procedure, which adds pressure on a team that's like, oh my goodness, now not only are we counting what we have to make sure we get that other item out. Common reasons items are lost. Well, sponges are used incorrectly or maybe they weren't tracked. It's so important to maintain an accurate count. If your field is cluttered or poorly organized, that could be problematic. And counts are skipped or incomplete can also add to items left in a patient. So we as STs always keep track of our sponges and anything else that has to be counted as they're being used. But when are items most likely to be lost? Long procedures, 8 hours, multiple staff changes during surgery, lack of sponge tracking, and just having a field that is just a hot mess. Okay. Because then you're trying to figure out where everything is. So you're in a case and you're doing everything correctly. What happens when there is an item that is missing? You notify the surgeon immediately. Sir, ma'am, just letting you know we're going to be doing an extensive count. Um, we're trying to find a needle. We're trying to find a sponge. We're trying to find a hemostat. Okay. You see teams coming in and searching the trash. That happens. They're going through everything. You're checking your back table, you're moving your equipment, you're looking under anything that's hidden. Someone's coming in and they're examining the floor beneath the OR table. They're on hands and knees. We have a magnetic roller that we roll through the operating room that locates metal instruments. And a lot of surgical procedures, we're using very tiny needles. And if worst case scenario, we are asking for an x-ray. Everything's been exhausted. We've relooked in the wound. The surgeon knows we've got to request an x-ray. Okay. Because now we've got to try to find that item. We get steps to our cases. Okay. Patient comes in, they are carefully moved from their preoperative area, whether they've walked, they're in a wheelchair, they're in a gurney, and they're brought into the operating room. We position the patient on the operating room table according to our actual procedure. We're doing a spine case, we're trying to do L4, L5, they're going in prone. We're doing a belly case, maybe it's a laparoscopic appendectomy, they're going supine. Maybe it's an ortho shoulder, they're going in beach chair. Okay. Correct positioning, minimize pressure injuries. It makes sure that our patients are comfortable and allows proper access for us as the surgical team. Anesthesia provider is going to sedate the patient and they're going to monitor their vital signs. Now, this is extremely important because we want the patient to remain pain-free, stable, and unconscious during the surgery, preferably. And then if there's any issues with anesthesia, that can jeopardize the procedure. Our scrub nurse, our circulator, they are cleaning, disinfecting the surgical site using antiseptic solution. So they're doing the skin prep. They're just trying to reduce the probability of infections. They're trying to eliminate any type of bacteria around the incision site. So then we come in, we've gowned, we've gloved properly, and sterile drapes are placed to create a sterile field around the surgical site. Instruments are equipment, they're attached to stabilize drapes to prevent any movement because we don't want anything shifting. Then it's start time. The surgeon makes the incision, proceeds with the planned surgery. What we're doing is staying focused. We're communicating. We are being very strict to our sterile technique. We're ensuring that the best possible patient outcome is achieved. Each step just contributes to patient safety, infection control, and a smooth workflow, all which are important in achieving a positive surgical outcome. But we've got to manage our field. Sometimes that requires adjusting surgical lights to ensure the operation field is well lit for optimal visibility. There's a light handle. These are sterile. You can touch them if your surgeon wants you to. I've had certain cases in neuro where the surgeon would place the light where he wanted it, did not want a light handle, and the scrub or the circulating nurse would have to, if he wanted it adjusted, come and touch it on the unsterile parts. Otherwise, then we can kind of move it and manipulate it for our surgeons if they allow it. Okay, so just keep that in mind. We look at our sponges, and you can see a couple sponges on the slide. All sponges that are used in the surgical field during the operation has to have that radiopaque marker. And it makes sense, right? Because if we're doing our count and a sponge gets lost and it doesn't have that radiopaque strip, you're not going to be able to find it. So they all have to have that radiopaque marker just in case. X-ray has to come in and then we can locate it. This is the type of sponges that you're going to be dealing with. Raytax, they're small, they're absorbent, they're used for minor procedures, or we use them to kind of keep our instruments clean. Your laparotomy sponges, they're going to be a little bit bigger. These are large absorbent sponges used in abdominal or large cavities. Ratex would be for deeper cavities because they're thinner, so you can kind of stick them in. Laparotomy, these are large belly cases, most likely. Peanuts, they're not like the kind you eat, but they're like little small that we put on a peon, Rochester peon clamp. Some doctors will ask for other instruments, but they're normally on a Rochester peon. And they're for blunt dissecting or tissue manipulation. We have our round sponges, our cotton balls, a lot of times used in ENT. Neuro sponges, our patties, they're going to be thin, they're flat, and they're going to be for delicate tissues. A lot of times we use those under the microscope. Okay. You want to make sure that you have your accurate counts. I cannot stress that because it supports patient safety, and you do not want to be a part of a team where unfortunately a patient had some type of issue because there's a retained malleable instrument or Ratex, a hemostat left in a patient's body. We get to passing our instruments. Now, you replace your instruments with long ones as the surgical wound deepens. And it makes sense. When you first start off, let's say we're talking about a big belly case. At the surface, you're going to use smaller instruments. You may use your AdSense, you're going to have your knife blade on a normal knife handle. You're going to give them the Bovie tip, regular. As you get deeper, you go from Sin Rakes to maybe Army Navies to Richardson Eastmans to now they may ask for a whole like Omni retractor to open up the belly. That means that the deeper we go down, the longer your instruments are. As we come out of the belly or out of the larger cavity, your instruments are going to go back small. So we're really just kind of paying attention to where we are. If you're way deep into a belly, you're not going to give them small AdSense. You're going to give them something bigger like some DeBakey's. They're going to be a little bit longer. But as you guys get into it, it'll start to make sense. It'll start to flow because you'll be like, oh, okay, that's where we're at. Bet I got you. Okay. When we're talking about micro instruments, I grabbed this slide here. I was trying to find one with a microscope so you could kind of visualize everything. So picture it. Your doctor has their eyes looking into that microscope and they're asking you for instruments. They're not going to look away because let's say they have their eye on a bleeder and they're like bipolar forceps, okay? And they're going to have their hands ready and they're still looking. They're going to expect you to hand them in a position that as they're looking, as you hand it, they're going straight down. Okay. So it's kind of like straight down. And that's why it's so important to give things in position of function because a lot of cases, the doctors are kind of like, okay, I got this clamp. And you see, I'm not even looking at the camera because I'm like, clamp, my eye is where it needs to be. And they're going to want to have it in their hand and straight onto whether it's a vessel, an artery, etc. Does that make sense? Yep. Okay. Which means this is how you get good at anticipating. You start to learn each other. It is a dance. I've mentioned that some of my best cases is where me and my surgeon, he's not asking for one instrument. I'm handing him instruments and we're talking about something completely different. But we've learned each other. I've learned the case. He's learned how we move. I know how he wants things. I'm seeing how he manipulates, how he does different things. And then I start getting things ready for him. Okay. Now, if the surgeon is consistently repositioning an instrument after you pass it, this is where you start to learn. You modify. And a lot of times it's going to be suture. Okay. Because some doctors like the suture clamped in the middle, and you guys will learn this. But the first time I see a doctor change a needle, I'm automatically kind of watching, and the next time they ask for a needle, I'm putting in the closest position from what I've seen, and I'm handing it to them. Okay. You're also trying to avoid jarring the microscope. The first time you get in those microscope cases, you may be nervous, and that's okay. Take a deep breath and go. Okay. Don't think about it, just go. When you see the surgeon and they have their hands out, no, they are not going to look at you. A lot of times they really can't. All right. That's when you take your breath grab the instrument, and with confidence, hand it to them. All right. This is where we talk about anticipating the surgeon's needs. We're adapting to their preferences, and we're trying to make a smooth and safe surgical procedure. With that, there's a thing called the neutral zone. And the last part of finishing up chapter 18 talks about this. It is only a designated area on the surgical field for placing and exchanging sharp instruments like a basin. A lot of times in big neuro cases, we have, or even general cases, we have a magnetic pad, which is, see if I can grab, which is this right here. The instruments will not roll off. We place this on the field. A lot of times they're green. The image I found was purple, but a lot of times the ones I've used are green. This goes onto the field, and these instruments will not roll off. A lot of times we may use these, and I've used them in shoulder cases just because the patient is in beach chair and our field, our sterile field changes. Okay. We have our basins. This prevents hand-to-hand contact, reduces the risk of sharps, and it does help ensure safety for surgical teams. So this is what they mean by a neutral zone. Your knife handle would go in the basin and you would pass the basin to the surgeon. I'm going to use um, remote control. So imagine this is the basin and my knife is in here. I'm handing it like this. The surgeon will grab the knife. When they're finished with the knife, you still have your little basin. They put the knife back in. And that is a neutral zone. Otherwise, you're going to go ahead and hand that knife like a pencil. Okay. It's all going to be one, your facility, what they're comfortable with you as a student. And two, a lot of times as a surgeon, true story. We had a surgeon at a hospital and he was known for not saying stabbing a lot of his residents, but a lot of his residents kept getting stabbed for whatever reason. And he would be like, well, they got to move their hands fast enough. Hey. So for him, I'd be like, if I had to hand him something, I'd like put it next to him. There it is right there, because I'm not gonna get stabbed, right? And everybody knew who he was. So it's not like it's gonna be a, oh my goodness. But that just goes with the flow. Okay. And you like again, you learn the surgeons. Okay. Now, as we continue, we get into intermediate and immediate postoperative period. And we're starting this chapter. So tonight, we're going to look at what we do intraoperatively. We're going to talk about the Halsted's principles of surgery. We're going to talk about hemostasis, not homeostasis, but hemostasis, which is controlling bleeding, versus homeostasis, which is balance. And I always want to make sure that because once you guys get into pharmacology, you're going to hear homeostasis, but these two terms, because they sound so much alike, do get confused. Hemostasis is where we're trying to control bleeding. Okay. And then we're going to talk about how surgical sponges, again, are managed. Now, right off the bat, we get the surgical wound. We have to protect the wound. We maintain sterility just to prevent any type of contamination. With hemostasis, we're trying to control bleeding. We're trying to keep the field clear and support healing. When we talk about exposure, the doctor may say, hey, Chantel, I need you to hold this synrake so that I can get exposure, which is just visualization to the surgical site. And then they may say, Alexis, I need you to handle this hemostat gently because you're going to be protecting the tissues for me. They talk about tissue viability, keeping the tissue moist and undamaged to promote healing. And you're going to learn this. There's certain parts in the case where you're going to be handing them different types of wet sponges just to protect the skin edges before certain retractors go onto the body. When we look at restoration, I want you to think of, let's say, an Achilles tendon. Okay. They may say, hey, Destiny, you're assigned to this Achilles tendon repair. Just know that we're going to try to properly align the Achilles, bring it back together so that it can have some type of functionality. Or they may say, we're just going to close tissues. One thing that we do a lot is eliminate dead space. There's going to be pockets. Okay. Not to gross anybody out, but let's say you have a huge ulcer, okay, a pus-filled ulcer, and you're coming in for, sometimes we do decubitus ulcers. So the patient's coming in, or even polyneurosis. You have this huge ulcer, we open it up, we drain it. Well, keep in mind that the skin was swollen at first. And then we get all the crud out of there, we get the sac out, and now there's just empty space. So we want to eliminate that dead space. And that's what they mean by that dead space. It's just that pocket that was filled with fluid or pus or whatever was in there. We start when it begins and then when it ends. Okay, so we start with the incision, cut time, and it goes all the way into the healing process. We play that big role. And I know I've been saying it a lot, but we do. We help with wound healing. We are helping support the surgeon. We're maintaining a sterile field, a safe environment to help that patient heal just that much quicker. Oftentimes, we are bringing patients in because we want to know what's going on with them. We're going to remove something. Specimens are removed for pathological studies to diagnose or determine treatment. We are responsible for properly handling and sometimes labeling the specimens on our field as we pass it off, because we need to know what we're passing off. This is very important because, again, you do not want to be that team that has to tell a family of a kid that, hey, we lost their wedge, their lung biopsy. We need to now bring your baby in again to get another one. So losing a specimen can delay diagnosis or require a repeat procedure. Mislabeling can lead to errors in diagnosis and, of course, treatment. And not marking cancerous margins or tissue origins can affect treatment. Now, that's not necessarily on us, but it's still, hey, doc, is there anything that I need to know about any of these markings? Okay. Every item removed from the patient must be recorded and submitted for some type of analysis. The only time that I did not have to do that is when we did an amputation of a foot. Okay. But we have to ensure proper care, which is very important for patient safety and accurate diagnosis. So let's talk about some specimens. Specimen management and guidelines, again, is important. Properly identifying each specimen to ensure its record correctly. And you kind of see how the doctors will mark it. Sometimes they'll just tag it and they'll tell you what the sections are. And this is important because they're going to report this to the nurse to give to the pathologist so that the pathologist can actually have a better idea of what they're actually looking at. Always label specimens with the patient's information. Okay, that's going to be the circulator. They're going to have that patient's information on there before the runner comes in to take it. Do not pass a specimen off the field until the surgeon has approved it. Okay, sometimes they want to add more to a certain specimen. So do not. You don't also want to wrap sponges around specimens. And this is why sponges can hide the specimen, making it easy to accidentally get discarded. Because remember, for us, when we're using sponges, sometimes it's to wipe our instruments, it's to, help with bleeding. So a lot of times, if we're wrapping a specimen in a sponge, our normal instinct, muscle memory is like, oh, this is used, let me toss it. So try to not ever do that. Okay. All tissue removed must be preserved for potential examination. So even though we didn't take our foot to pathology, we still put it in biohazard just in case. Now, sutures are part of the marking process, and that's what you see here. You have sutures, okay? All they do is help identify key areas of the specimen, especially for cancer margins, and should not again be removed. We use a protective container. We place a specimen in a visible protected area, such as a specimen cup, which we would have a sterile specimen cup on our backfield, or a container, which would be sterile as well. And you, again, want to make sure that you don't accidentally lose it or throw it away. All right. Now, getting into the actual types of specimens. We have a tissue biopsy. The very first one you see is an excisional biopsy, where we remove a small portion of tissue just to look at it. With a fine needle aspiration, okay, we're using a thin needle to extract a small sample of tissue or even fluid. Sometimes we'll use a larger needle to remove a core sample of tissue, and that's a core needle. For our frozen sections, this is going to be a specimen that requires immediate analysis, often during surgery, to assist with decision making. These are going to be your staging cases. So if you hear, let's say Donna, they say, hey, Donna, you're going to be in a staging case. I want you to mentally prepare that you may be in there for a while, because what we're doing is we're grabbing different parts to ensure that we are kind of touching every part that could potentially be of, I don't want to say cancerous, but could be potentially something more that we need to look at, making sure that we got everything. So you're going to be taking a lot of specimens and waiting. Pathology is usually on the phone or waiting downstairs on the phone or wherever the pathology area is. And they're letting us know, hey, you're good. No, I need a little bit more. And so the surgeon will go back and take more. Okay. So those are going to be your staging cases. The other thing to remember is because these are fresh, frozen sections are transported on Tefla with saline, just a little couple dips or squirts of saline to maintain tissue integrity until analysis is able to be done. Now we have the chapter talks about microscopic analysis where the specimen is grabbed and it's looked under a microscope, and now we can get a definitive diagnosis or determine the nature of the abnormality. We sometimes get fluid. We'll take a syringe and they will literally, if there's a lot of pus in a certain thing, they're going to take that and send that off to pathology. It could come from muscles, it can come from bones, it can come from organs like your liver, your lungs, your kidney. It's going to be collected for analysis just to assist the diagnosis and treatment for different decisions. We have other specimen types that you see in front of you, and we have forensic evidence. We talk about amputated limbs. I mentioned that. Now, for forensic evidence, certain items removed during surgery, such as tissue or objects, may be a part of forensic evidence, like a bullet, and should be handled carefully because there's a whole chain of command that's going to go with that. The items can be handed over to the police for further analysis if required by law enforcement. Don't freak out, but just know that that could potentially happen depending on if you do have a patient coming in with a bullet wound. Okay. And then when it gets to that foot that I mentioned that was amputated, it depends on the patient's wishes. The patient's wishes determine the handling of an amputated limb. It may be sent to the mortuary and retained there until the patient's death, if necessary, based on the patient's preference or legal requirements. And of course, that's going to depend on the patient's status, right? Now, we talk about going to the mortuary. That would be if the patient had been deceased as well. We're not just sending a foot randomly to the morgue, okay? But again, that's going to be dependent on the wishes of the patient, okay? So I saw a question. Let me go back. What are the specimens on the screen? This one or the one before? The one before. Okay, okay. So here is just a biopsy of skin. Sometimes we'll take superficial layers that look like they have what we call a nevus. A lot of dermatology does that a lot. And what we'll do is we'll kind of take a superficial epidermis layer and mark it so they can send that off. A lot of times you're looking at a other side of an amputee or amputation. Okay, so again, this is going to be one that may or may not go down. We have this one is more of a deceased. This one looks like a deceased. I don't want to say organ, but to me, this one is more like after like an autopsy. Does that make sense? And then this one came with it, gonna keep it transparent. This one came with the other ones, and then this is it underneath the microscope. So the portion that they kind of took off, I'm assuming they wanted this sent off, and now they can look at it underneath the microscope. This one I'll have to come back and check on with you. So I'll get that to you this evening.
At first, I thought it was fibroids. That's why I asked.
Yeah. Yeah. Uh, It kind of, but no. But I will definitely find out for you guys, and that's a great question. Um, for you guys, and I'll have that for y'all this evening. Any other questions on that? All right. Now, when we pass off these specimens, we're going to, of course, have them in the proper container. Circulator is a little bit too close for me, but that's okay. That's the image. We make sure that everything's going to be documented on time. That's really going to be for the circulator as well. But for us, we want to make sure that we're putting it in the correct medium, meaning for us on the field, it's saline. They may have to put something in formalin for them. The surgeon should orientate the specimen to the location within the body, and they're going to tell us, hey, that suture is located proximal or distal, and you're writing that, like you're writing exactly what he's saying. We have um, labels on our field, sterile labels and a sterile marker, and we're writing this stuff down, placing it on the specimen before we even pass it off. All of these steps just ensure the specimens are handled correctly and safely for proper analysis. There are some steps. We have to identify the specimen. What is it? What are we doing? With that, the circulator is going to have the patient's name on it, the type of tissue, where it came from, biopsy, tumor, the origin of it, a biopsy of the liver, a biopsy of the lung. You're also going to know the relevant information, the suspected condition, like we are ruling out metastasis, you know. We identify sutures, tattoos. They may be made by the surgeon to orientate the specimen correctly. Of course, we're going to have a date, we're going to have a time, and then it's going to be preserved correctly, meaning in formalin, in saline, with a Tefla. Now, we talk about Halsted's principle of surgery, and this is really big, okay? This is an image of Halsted back in the day, okay? How everything kind of came to be. We treat tissue delicately to prevent damage and support healing. Here's that word, hemostasis. We want to ensure bleeding is controlled. We want to maintain as much of a clear surgical field and prevent complications. I go back to the term theater. This is where it came from. So what we are seeing is a picture looking down, but I want you kind of to picture a theater, like where you go to the movies, where there is stadium seats. There's stadium seats, and then this is in the front. Okay. We maintain the blood flow to tissues to support healing and prevent tissue death. We use sterile technique because we want to avoid infection and ensure the wound remains clean. We avoid unnecessary tension on tissues. So that's where you may have the doctor say, Andrea, I need you to kind of hold a hemostat. Keep in mind, it may be attached to a vein. It may be attached to an artery. It may be attached to just skin. And so when they hand it to you, you try your best to just maintain however they have you held it. And you don't want to pull or anything because you may pull something that should not be pulled. Okay. We have that comprehensive approach to wound care. It's considered healing process. We think about potential complications, but we hope for the best outcomes for our patients. Now, there's a couple ways that we achieve hemostasis, control of bleeding in the surgical field. Sutures, one of the easiest things we do, we grab a bleeder, we grab a suture, and we start tying it off. The surgeon, not us, okay? But we're passing them those sutures. A lot of times we pressure, we'll give them a sponge. They may ask for a Statinsky, which is a vascular clamp. Okay, let's say you're doing vascular surgery, heart surgery. You're going to use a vascular clamp. You're going to clamp it on that bleeding artery. A lot of times or vein at two places. We use our bovie a lot. And there's also biochemical means. Okay, so We have Liga clip appliers, which is little clips that you'll load and have it ready for them, and they'll put it on there so that bleeding is stopped. The biggest thing is controlling bleeding is important. We do not want our patients to bleed out on the table. Okay. We clamp and ligate. Okay. Again, sutures, bovie, hemostatic agents, but sometimes we do what's called thermal and high frequency coagulation. A lot of times you'll hear us saying we're going to use the harmonic scalpel. Heat is applied to coagulate and seal blood vessels, preventing blood loss. Our bovie controls bleeding. It compresses the blood vessels in an extremity. Sometimes there's autotransfusion. Now, this method involves collecting and reinfusing the patient's own blood just to maintain blood volume during surgery. We also have active hemostats, um, quick clot. Okay. These help stop the bleeding. Gelatin sponges, absorbable hemostats that will get in there to stop profuse bleeding. We also have gel-like, does the same thing. We have fibrin, does the same thing. This is the final stage of the clotting process. Um, I use a lot of fibrin in neuro cases. Okay. These methods and agents are so important because, again, we want to control bleeding in surgery. Now, we use tourniquets a lot. If you are an ortho connoisseur and you're like, you know what, that's where I'm going. I want to be with bones and joints. Ortho, believe it or not, is one of your less bloody surgical services. And it's a lot because we use tourniquets. The period between tourniquet inflation and deflation is going to be your tourniquet time. I have seen that question before. Okay. Tourniquet time when it inflates and deflates. With deflation and reinflation, if surgery exceeds the recommended of inflation time, what we do is we take down the tourniquet, which we have done cases before for 10 minutes. When that happens, blood starts to flow. But then what we do is we re-inflate it after the 10 minutes. We have an Esch mark, which is a kind of rubbery ace bandage. And what we do is we raise the extremity up, and you guys are going to see a really quick video on it. We raise the extremity up, we wrap it, hold it up, turn up the tourniquet. Once the tourniquet is inflated, we bring the extremity down, take off the bandage. Quick thing that most techs do, we re-roll that Esch mark, okay? Because you just never know. A lot of times I have seen techs like that aren't comfortable in ortho and they get the Esch mark back and they don't do anything with it. If you have time, re-roll it because you never know when a case goes longer and then you've got to reuse it, okay? For upper extremity, I have seen this question. Tourniquet can remain inflated for up to 1 hour. After 1 hour, we take that tourniquet down. We wait our 10 minutes. We re-esch mark it, re-elevate it, re-inflate. For lower extremities, it can remain inflated for 1.5 to 2 hours. Exceeding this time can lead to nerve and vascular damage and tissue necrosis due to tissue death. Okay. For adults, the pressure should not exceed 50 to 75 mm. And this is systolic pressure for the upper extremity. And then for lower extremity, 100 to 150. For our babies, our pediatric patients, for our upper, it's 100 mm above the systolic pressure. So let's see how this is done really quick. So there is no word. So like I said, we grab the extremity. This is done unsterilely, okay? We put a protective um, cotton around the extremity just to protect the skin because that's going to be really important. And sometimes we do it with our surgeon. Sometimes the PA will do it. Sometimes the resident will do it. Sometimes, not necessarily the intern, but it's going to be somebody and they're going to go ahead and do this prior to even prepping a lot of times. So that you're just wrapping the extremity, preferably with gloves, but you'll notice ortho, sometimes they don't. They're going to grab the tourniquet, okay? And they come in different sizes, and you just want to grab one that's appropriate for the patient. We have really, really large ones, but you just want to try to find one that's pretty much appropriate size. And the way that this goes down, because a lot of times this gets confusing, there is a Velcro. So you want to pull as tight as you can with that Velcro piece. And then there's strings that you tie it in place as well. The other thing that you want to keep in mind where this connection is going to be, you do not want it to fall into the surgical field. So a lot of times, wherever the tourniquet machine is, we try to make sure that this piece right here that connects to our tourniquet is out of the way of our surgical field. Okay. And it's not obstructed. Now, this is optional. Um, a lot of doctors that I've used, we haven't used this part, but like you're gonna hear a lot. There's 8,000 ways to skin a cat. Okay, so um, they're putting an additional protection over the bandage. I'm used to going straight to the clear part. Okay, this is to kind of protect it from the surgical prep because once this is done, we're gonna prep. Okay, so now they're putting on additional barriers. Keep in mind, there's someone still holding that leg up. Okay. And ideally, you want to go around the entire circumference of the leg. And that's why you see she's going to kind of protect it if you're going to um, use this particular type. So this is kind of stuff you already know. You want to avoid pooling when you are disinfecting. You want to make sure that the skin and soft tissue under the cuff is well protected. And that's where we put that first layer of cushion around. And then at this point, you have the circulator or some additional person prepping that leg. And for them, if you're assisting, because sometimes we'll go in and assist, you want to prep closest to when the surgeon comes in. Otherwise, you're holding that leg sterile until they come in. And sometimes it can get kind of heavy. Okay, so just keep that in mind. Different sponges, again, from Raytex to laparotomy to sponge dissectors. A lot of times we use these in ENT. These are going to be more neuro. These are your Kittners, those little ones I was talking about. This is what we call peanuts. So peanuts, aka Kittners, okay? They're going to be the ones on your peon, Rochester peon, or if you have a surgeon, some use hemostats, but most likely they will be on Rochester peons. We will teach you how to load them in the lab. I feel like this is the very first time we actually are able to get to a game. So before we get out of here, if you guys, if you can, only 5 questions because I wasn't sure if we were going to be able to get to it, but there's only 5 questions. It's going to be based on what we talked about this evening. If you're driving, don't stress. You'll be able to see the same questions. And if you're watching the archive, again, you will be able to see these questions. Okay. So here is the game pen. So if I can put this in. As per usual, I will send you guys the link in Moodle. Am I able to get the link? So that you guys have it. And I'm going to join too. Again, 5 quick questions, nothing crazy, just what we went over today. You will get your today, you're going to get the final review. There's also a Quizlet I created for that as well. So be on the lookout. What I'm going to do is pin it to the top of your announcements. Okay. I have 11. Do I have anyone who is not able to join? All right, we are going to go ahead and start. So if you have not been able to join, don't worry, you'll be able to follow along with us. Let's start. Maintain a sterile fill and pass instruments. Next question. Remember, I explained one is going to be kind of, you can kind of stick in deep, and the other one's going to be more large. The other two, we have neuro and you have your cotton ball. So just think about which one that you kind of go in deeper. So it's the Raytax. Your laparotomy are going to be for your bigger, wider cases. The Raytax, you can kind of spread out. Use my eyeglass thing. They are going to be a lot thinner. So you can actually kind of think of kind of being able to pack them because you can kind of pack them and then pull them back out. Okay. We want to prevent hand-to-hand contact with sharps. Okay. And when you think about my doctor that I mentioned, that a lot of his residents were stabbed a lot. Okay, so I like this because this is a question that gets missed. So when we talk about a method and a which one is not a method for controlling bleeding during surgery? So I want you to think of it this way. Of those, your case is already going. So let's say we get a bleeder. Now we need to control it. Now we need to get back to hemostasis. It's going to be sutures. We're going to put sponges because we're trying to control the bleeding. We may use a bovie. The tourniquet is to prevent the blood flow from even starting. Okay, so that kind of helps break that down. So the other three are it's during the surgery. One we do before the case is even started. And the last question. Okay, so you get it. So if the Raytex is going to be for the smaller cases, your laparotomy sponges are going to be for those larger cases. All right, good job. And like I said, I'm going to send that to you guys this evening. Quote of the week. The only way to do great work is to love what you do. For those of you that are watching the playback, I have three questions for you. How does your role as a surgical tech impact patient safety during surgery? What does it mean to maintain a sterile field, and why is that important for patient outcomes? And the last one, how can your attention to detail make a difference in high pressure surgical environments? We covered a lot of key topics to the role of surgical techs, and how we keep the field safe. We talked about maintaining sterile field, how having an organized field does make it a little bit easier not to have lost items. We explored various methods of hemostasis, including surgery, electrocautery, bovie, tourniquets, and their role in controlling bleeding in the different aspects. This session really focused on proper handling of surgical specimens, emphasizing the need to have correct documentation and identification to prevent serious mistakes. We finished up and reflected on just different things that we do that impact work patient safety and surgical success and our overall team dynamics. What questions do you have for me? All right. So a couple things. I'm going to be going back, getting the actual specimen name for that slide, and I'll be sending you guys the Moodle, in Moodle, the Kahoot for this evening. I do want to encourage you guys to keep pushing. We are almost to the finish line. You guys, I am so proud of y'all. Like, this is a lot of information that y'all have tackled, and y'all are doing phenomenal. So please, please, please keep that momentum going. Okay. We have a couple weeks left. We get a break, and then you guys are off to the next chapter. Again, this week, career services will be here, I promise you. So for everyone that can attend, I look forward to seeing you on Wednesday. You guys have a great evening. Good night, everybody.